This is Dr. Molly Baker. With the help of Dr. Dylan Gerlach and Dr. Caitlin Gordon, we will be presenting large vessel vasculitis, a rare presentation of mucormycosis. Mucormycosis is a rare fungal infection of patients who are immunocompromised or have underlying diabetes, presenting with localized rhinocerebral, pulmonary, or cutaneous involvement. While the clinical presentation of localized mucormycosis is well described in the literature, the extremely rare presentation of disseminated mucormycosis causing large vessel vasculitis and its potential complications are not well described. The case report that we will be discussing is that of a 31-year-old male with a history of IV drug use, endocarditis, status post-aortic valve repair, invasive mucormycosis causing mycotic aneurysms and thoracic aortic aneurysm, treated with amphotericin B and lifelong posaconazole, who presented with sudden left abdominal pain and flank pain. Pain initially began at rest 4 days prior to admission with associated diaphoresis only. Vital signs are largely normal and patient was stable on room air on admission. Lab work was pertinent for a white blood cell count of 13, a lactate of 1.23, and a creatinine of 1.38. Blood cultures obtained showed 2 out of 2 positive for coagulase negative staphylococcus. CT angiography of the abdomen showed a descending aortic graft along with a focal dissection of the abdominal aorta, as seen in Figure 3, as well as a dissection at the origin of the SMA, as seen in Figure 4, and then bilateral renal cortical infarcts left greater than right, as seen in Figures 1 and 2. Infectious disease was consulted for the 2 out of 2 blood cultures, positive for coag-negative staph, and a TEE was also performed, which showed an aortic arch mass thought to be consistent with a thrombus versus a vegetation that carried a high risk for potential embolization. Given the type B descending aortic dissection, vascular surgery was consulted and recommended no surgical intervention. The patient was then transitioned to daptomycin for treatment of bacteremia, as well as continued on lifelong posaconazole. Mucormycosis caused by a group of fungi known as Mucormycetes are uncommon in previously healthy individuals, thought to be roughly 8% of total cases, and it is a frequently fatal infection that typically occurs in those with underlying disease, including diabetes, which is found in over 50% of cases, or those who are immunocompromised. Interestingly, the patient in our case report was previously healthy and without a history of diabetes or immunocompromise. Mucor most commonly appears in the paranasal, rhinoorbital, and rhinocerebral regions, making up 44.2% of all cases. It also occurs in the soft tissue of the extremities, renal areas, and pulmonary areas, as well as gastrointestinal areas. It can also appear as disseminated disease, as seen in 11.6% of cases. Given the known frequency of localized infection compared with disseminated disease, this patient exhibited one of the rarest manifestations of mucormycosis. A study of cases in one hospital over the last 50 years suggests that the incidence of mucormycosis is increasing. Even with the increasing incidence of mucor infections, there have been few case reports describing disseminated mucor resulting in large vessel vasculitis. Our team found a similar case to our patient in which a previously healthy 35-year-old man presented with similar symptoms and CT scans indicative of multi-level vascular occlusions causing nephrotic and splenic infarction, which led to a diagnosis of large vessel vasculitis and progressed to vascular dissection. While localized mucormycosis is well described, the complications that arise from disseminated mucor, such as aortic dissection from large vessel vasculitis, as in this case, are infrequently discussed and should always be considered in patients with a history of mucormycosis and new abdominal pain.